Hello and welcome to CalHIPSO's educational webinar series. Today's webinar is titled MIPS Reporting for 2018. My name is Chloe Scholl and I will be the organizer for this webinar. All attendees will be in listen-only mode for today's session, so if you have any questions throughout our time together, you can submit them in the chat box, and if time allows, we will try and answer a few questions at the end of the presentation. Today's webinar is being recorded and will be available at www.calhipso.org in the next few days. I would now like to introduce the Executive Director of CalHIPSO, David Ford. David?
Thank you, Chloe, and thank you to everyone for attending today's webinar. As we get started today, I would just like to do a brief introduction for anyone who's on the webinar who may not be as familiar with CalHIPSO and the role that we play in the health marketplace. CalHIPSO was founded in 2010 as a joint effort of the California Medical Association, the California Primary Care Association, and the California Association of Public Hospitals and Health Systems. We were the largest of the 62 federally designated regional extension centers by the number of providers served. And in that role, our job is to help safety net healthcare providers navigate the world of electronic health records and health information technology. Although CalHIPSO was originally founded as the REC and originally for the purpose of helping providers access meaningful use incentives, we've since branched out into different areas of health information technology. And so while we are still doing some work in Medi-Cal meaningful use, we've also started helping providers with the Quality Payment Program and MIPS, which of course is the subject of today's webinar. We're doing some work on diabetes reporting, encounter data, and we're just launching a big program to help providers interact with health information exchanges. Across all the programs that CalHIPSO has done over the last 9 years, CalHIPSO has helped more than 13,000 unique providers, and providers working with CalHIPSO have accessed more than $250 million in federal incentives. And so for today's webinar, CalHIPSO has invited in our colleagues at SA Ignite, and we're very pleased today to have the CEO and founder of SA Ignite, Tom Lee, on as one of the presenters today. And he's joined by Leslie Athmer from his team. So I think at this point, without further ado, we will pass the webinar over to them. Tom, thanks for being here.
Great. Thanks, David. Thank you all for being here. Leslie and I are very excited about the information we have to share. Leslie, do you want to say hi real quick?
Hi, good afternoon. Thanks everyone for joining. I'm the Director of Customer Success at SA Ignite and looking forward to walking through this webinar with you.
Great. And so for those of you who may not be as familiar with us, we are a cloud solution company for helping to automate and simplify value-based care programs such as MIPS. We built up a lot of domain expertise since the early days of meaningful use with both our software as well as services. I hope to share some of that experience with you today in terms of 2018 MIPS reporting. We're proud to say that for last year, our customers achieved an average MIPS score of 95. And we're really committed to helping all provider organizations continue to do well in MIPS and also really assist with the overall transition to value-based care with what we can deliver. All right, so without further ado, today we're going to cover the basics of 2018 MIPS. We're going to talk about kind of two predominant modes of approaching the program this year, which are folks who are kind of walking at a walking pace and those who are at a running pace. Then we'll also talk specifically about, now that we're in Q4, what are some key activities that you can really look at embarking on, or decisions you can make that can still impact your 2018 performance. And we'll also take a bit of a look into 2019 in terms of how that's shaping up from a MIPS perspective. Okay, so the basics of the program. And so really, we're going to kind of start from a very foundational level of knowledge. For some of you, this might be a refresher course in some sense, this portion. But the program is so complicated, as many of you all know, that it can also help to hear things a little bit more than just once. So first, let's talk about the eligibility for the program. So fundamentally, there's certain credentials that are included for this year that you can see up on the page, including nurse practitioners, nurse specialists, and nurse anesthetists. Then the second part that's also important, we'll come back to this a little bit more later, is you have to, as an individual clinician, one has to meet certain thresholds for Medicare Part B from a dollar perspective on an annual basis, allowed charges, as well as in terms of seeing a minimum number of patients. And if you, as a clinician, meet both of these requirements, then you will be eligible for the program. And we'll talk a little bit about how you can get this type of insight from CMS directly to tell you if you're over these thresholds. And then finally, in order to be eligible for MIPS, a clinician cannot be a qualifying participant in what's called an advanced alternative payment model, which is sort of the other track of the QPP program. An example of that is in the ACO program, Medicare Shared Savings Program, Track 1 Plus program. In a nutshell, it's models where there is providers are taking on downside risk within the model, and if they meet certain requirements, that excludes them from the MIPS program. Okay, so these are kind of three of the main planks around eligibility to give you a little sense of what goes into that. Now, the other aspect of MIPS is that you can choose what type of entity you want to report as. So, for example, an individual clinician, as identified by their NTI number, is able to report for the program on his or her own and earn a MIPS score out of 100 that is tied directly to that NTI number, or more precisely, it's the tax ID and the NTI combination. Okay, but for all practical purposes, it's this individual clinician. The other way to report is to really look at it from a group perspective. And if you've got a practice of, let's say, 5 providers, you can all report as a single group under your tax ID. And the data that you would report would be the sum of all of your data across all of these providers. And it would be one block. And the one score that would be assigned to the group would be inherited by each of the individual clinicians. There's a third way, which is it's a newer way of reporting, where individual groups that each have up to 10 clinicians can actually band together into what's called a virtual group and report that as an entire entity, and then all the individual clinicians would then inherit that score. So that's a little bit newer. It's not as well adopted as these first two, which will really be what we'll come back to later on. Okay, so this is a decision that you can actually make on an annual basis, whether to report individually or as a group. Okay, so how do you check your eligibility for the program? So CMS has a lookup tool here on the QPP portal, and what you do is you enter in your NTI number, and then CMS essentially does the eligibility calculation for you and lets you know whether you're eligible. So, for example, this is an actual record that's come back from one particular NTI number. You can see here that for this individual clinician, the CMS has determined that as a clinician, the minimum amount of allowed charges, the $90,000 threshold, is not being exceeded. And so this clinician is actually excluded from the program if reporting as an individual. But if that same clinician were part of reporting as part of the group or the tax ID that they're part of as an entire practice, then as an entire practice, the charges, the charge minimum threshold is being met. And so that group as an entirety is eligible. And as a result, that clinician would actually be eligible for the program if reporting as a group versus as an individual. Okay, so there's much more. There's a lot of other aspects of this of eligibility that you can also learn from the site. So, Leslie, do you want to chime in with some of the things that you've seen on the participation site here?
Yeah, absolutely. So a couple things that we've found as we're helping our customers determine their eligibility. You may think that your clinician is only practicing at your organization. However, when you look up their eligibility, they're actually listed under multiple TINs, and it can be a surprise. So This is pretty common. We're seeing that quite a bit. And if a clinician does bill under multiple TINs, it's almost as if they're two people because they do need to submit under both of those TINs that they bill under, which is different from, the previous MU days. So it's definitely helpful to review your list and the eligibility and make sure that it's accurate and that you're not missing any of your clinicians.
That's a great point, Leslie. And to kind of reiterate what a key part of what Leslie said there was that it's the combination of the tax ID or the TIN and the NPI number that is considered to be an individual clinician within the MIPS program. So you can't have more complicated scenarios if the clinician is delivering care at multiple TINs, and those are all separate entities from the point of view of the MIPS program. Okay, but those are definitely things, the types of questions that our friends here at CalHIPSO can certainly provide you more guidance on that. We'd be happy to help too. So if there's questions around that, please submit those, or we can follow up with you afterwards. Okay, so how are you measured for MIPS? How do you earn a score out of 100? So at a high level, there's 4 different categories of performance. There's quality, promoting interoperability, which really has its roots in meaningful use, improvement activities, and cost. And you can see how the weights are across these 4 different categories for the 2018 year. Just go a little bit more, tell you a little bit more about these individual categories. So within the quality category, there's a number of different ways to aggregate data for and calculate measures. It's called a collection type, and we'll go through some of those in a moment. But generally, for most of these collection types, an organization or an individual clinician would select 6 measures out of more than 270 possible ones, and choose to submit those to represent their performance. And it has to represent the entire year of performance, the entire 2018 year. That's the reporting window. For the promoting interoperability category, we'll go into this in greater depth later, but there's certainly a set of measures here. You'll see a lot of familiar measures there from the meaningful use days if you were involved in that program before. The measures are calculated by the EHR, and you have a minimum 90-day period in which you need to report on. Improvement activities is a list of more than 100 different individual activities that CMS has created and defined, and you pick between 1 to 4 activities to get full credit on this. The number of activities depends on your particular situation, and we'll go through one example later on. And by attesting that you've performed those activities for at least a 90-day period, you are proving to the MIPS program that you are making a concerted effort to really go through a practice improvement and transformation really on the path towards value-based care. And then finally is cost. And so this is really Medicare expenditure in terms of how much your patients are costing a Medicare program. And there's currently 2 measures that are within this category. They're claims-based, meaning that you don't have to separately report any additional data beyond your claim stream, and that these measures are metrics for a full year. Okay. So let's now look at how does the financial impact of MIPS relate to the points that you earn. So first on the left side here, just draw your attention that in 2018 year, there's a maximum penalty of 5%. And there's these different point thresholds that are very important to understand on the, you can see it reflected on the graph here on the right. And so what's plotted here is the number of points along the horizontal axis. And then vertically is the payment adjustment factor, or the percent of your Medicare Part B payment that will be adjusted up or down based on what your score is. And so the first threshold to keep in mind is what's called performance threshold. And for this year, it's set at 15 points. And what this threshold sets is the point at which you have to be above in order to start earning an increasing incentive. But if you fall below that threshold, then you fall into a penalty zone that increases the further that you get to 0. The second break point here is called the exceptional performance threshold, which for this year is set at 70 points. And if you exceed that number of points, you will have an accelerating incentive. The prediction for this year is that this maximum incentive will be about 2%. So about the same as it came out last year. Last year it came out to be 1.9%. CMS had predicted around the 2.3% prior to last year. And so this, well, we'll kind of come back to this as well, is that this incentive is projected to further increase in future years as the program progresses and becomes more difficult. Now, there's another side of the impact of MIPS, which is on public reputation. So all of these scores out of 100, for example, for the 2017 year, will be publicly released by the end of this year through the CMS Physician Compare website, which is consumer-facing. And then in addition, there's also going to be a free downloadable file that contains all the scores nationally that third parties, such as folks like these, can really use within their physician ratings and for other purposes. So certainly we see a lot of kind of interest and questions around how these scores are going to be released and used in the public domain. And you know, Leslie, I'm kind of curious about in terms of what you've been seeing in the field and how that's evolved, you know, in the last year or two, and now with these scores coming out fairly soon. What if you mind sharing what observation you've had in the working with some of the organizations out there?
Yeah, I think it's a little cyclical. So what really caught everyone's attention when MIPS was first released was this concept of this public reporting and this ability to compare the results publicly. Now that, you know, it's been 18 months and nothing has yet been made public, some of that media buzz has died down a little bit, but we do expect that once it is published within the next few months, that media buzz is going to pick up again, and it'll start to drum it up again. You know, all along, we're still anticipating that these third-party vendor sites will take that public file and integrate it. And we don't really think it's any mistake. You know, CMS knew what they were doing when they implemented a 100-point system. The 100 points is very intuitive. It's very easily for the public to understand and relate to. So we think it'll be generally pretty easy for the consumers and the public to understand once it is published.
Right. Thanks, Leslie. So one housekeeping item for many folks, and if you have not yet done this yet, please do soon, is to get your 2017 MIPS feedback report from CMS. And so we have some links here. I believe that these links will be available to you afterwards. But essentially what you need to do is you need to log on to the QPP website using your EIDM account. If you don't know what that is or how to get it, there's a link here for you to learn about how to do that. Once you get that report, here's an example excerpt from one. You'll see your score, the breakout by the 3 categories that were scored last year, as well as your payment adjustment. And one other thing to note is that if you should find some scores or numbers that you don't agree with, or you feel like there's an issue with, you have until October 15th to file a request for a target review from CMS. And Leslie, I know you've seen a lot of these reports in recent months. Anything you'd like to share?
Yes. So just a couple things that we've noticed from the organizations that we work with. Depending on when you pulled your report, you may need to pull it again. CMS has made a few adjustments to the reports. So when they initially released the reports, on the right-hand side where it shows you the payment adjustment and then the exceptional performance adjustment, they initially did not break those 2 components out. I think there were enough questions around whether that exceptional performance adjustment was included that they went ahead and actually updated the report to reflect that breakdown. And then additionally, they did change that final total percent adjustment. So initially it was 2.02%. And then as Tom mentioned, the final adjustment is now 1.9%. So they did update that based on targeted reviews that they had already completed. So I would recommend, depending on when you've logged or when you logged in last to pull your report, you may want to pull it again and just see if there have been any updates. And then as Tom mentioned, you can submit for a targeted review. So I just really recommend taking a look at your scores, making sure that you received what you were expecting to receive, and if not, go ahead and file for a targeted review. We have seen some anomalies for specific organizations, and we have recommended several of our organizations to submit for those targeted reviews. So just take a look, make sure you're getting what you were expecting to get on those reports. Tom, you may be muted. There you go.
Yeah, Tom, are you muted? We're not hearing you. Tom?
We may have lost Tom.
Hello, this is Tom again. Can you all hear me? All right. Yeah, there was some issue here with the webinar. I apologize for that. So the walkers and the runners. So one mindset is to really look at just doing the minimum to avoid a penalty. And that generally means trying to target a score between 30 to 60, so you're well above that performance threshold. And really looking at the program as strictly a compliance exercise. The other mindset is to really be a runner, and that's really targeting, trying to maximize your incentives, trying to get a target score in somewhere in the 80 to 100 range, so you're well above the exceptional performance threshold, really looking at ways to sustain that high level of performance as the program does evolve and become more difficult, and also looking at MIPS as beyond just a compliance exercise, but much more of as a change enabler or a catalyst for an organization to really start transforming and getting on the value-based care track. All right, here. Okay, so let's go through a concrete example of a walker. A walker might decide to only report on 2 different categories for MIPS. Let's say it's the promoting interoperability category and the improvement activities category, and essentially putting aside the quality category, which tends to be the most complex of the categories. And so for this example, let's assume that organization is using the 2014 edition of Certified EHR Technology, that they're reporting for promoting interoperability using that technology, the transition measures, or formerly known as modified meaningful use stage 2 measures, and we'll list a couple in a moment. Let's say also that it's a small practice with up to 15 clinicians, and they've decided to report as a group. And they've also further decided to simply report these categories themselves through the QPP portal. So a little bit of background on promoting interoperability as part of this. The promoting interoperability score is such that you try to get up to 100 percentage points within the category, and that's broken out into different components. There's a base score, which delivers 50% of that 100%, and then there's also a performance score, and as well as bonus points you can earn. So the main point I wanted to just point out here is that there's a path to at least get 50% in this category by just focusing on this base score. So with that in mind, let's come back to our example. And if we look at the promoting interoperability category, again, similarities to where meaningful use was before MIPS came along. In order to get those 50 points in the base score, you just have to report on these 4 transition measures. So first is conducting an annual security risk analysis. Think HIPAA compliance, IT security, etc. The second is to really simply report at least 1 patient for each of these 3 different measures: e-prescribe, provide patient access, so portal access, for example, and health information exchange, which is transmitting care summaries of care upon referral. And so pretty minimal bar here, just 1 patient each to reach the base score for these 3 measures. And then just one thing to note, which we'll also come back to later, is that these 2 measures here also can contribute to the performance score. And that can actually be, actually drive some additional points for you. Okay, so that's That's a sort of a minimal way of getting through the base category. Now, in improvement activities, the list of more than 100 activities is such that some activities are medium weighted and some are high weighted, that you can earn different numbers of points for those. So for the purposes here, there's a path to get a full score on improvement activities, which is just to pick 2 medium weighted activities, such as these two, by way of example. And in addition, for a small practice, they actually get more points for these medium weighted activities. You only have to report 2 in order to get a full score. So just by doing what's on the page here, here's how the points work out. Is quality, we're putting that to the side for now. Promoting interoperability, you get 50 points for the base score. Remember, those 2 measures that were part of the base score also give you performance score points. So if you only have 1 patient for each of those, each of those measures will still earn you a point each. Okay, so that's why there's a 52 here. And then if you look at how that stacks up in terms of the MIPS score you get out at the end, you take your 52% score and you multiply by the weighting on the category for MIPS, and that gives you 13 MIPS points. You score full on improvement activities, so that gives you 15 out of 15 possible points there. The cost category, you won't know for sure what that score is until after the year is over and you get your feedback report, so we'll leave that as an empty for now. As a small practice, CMS grants 5 bonus points simply by virtue of being a small practice. There's another bonus that's really related to how risky your patient population is, but you won't know that until after the year's over, so we'll set that aside. And so really what you end up with is an estimated minimum score of adding up the parts that you do know ahead of time or have control over of 33 points, which is more than double of what the penalty avoidance threshold is. Okay, so that's just a simple way of kind of getting over that minimal bar. Now you look at this and you know, there's different ways to look at this. One is, okay, I'm over the bar safely, but then on the other hand, the score is also going to be publicly published. Okay, so that's part of this thinking about the transition of going from walking to running, not only in terms of what you need to do, but what might be driving your what might be driving your level of effort within the program. So to really make that transition and continuing our example that we just showed about walking, well, what more do you need to do in order to really get into a running mode? And the big thing, additional thing you need to do is to really focus on that quality category, because that's the highest weighted category of 50 potential points out of the 100. And so in order to really report on quality, again, typically you're picking 6 measures, full year performance, and there's a variety of different ways to report. So you could use your electronic clinical quality measures that are calculated out of your EHR. You could work with a third-party registry vendor to calculate some additional types of measures. QCDR, that's yet another flavor of registry. There's web interface. That's a more kind of manually intensive reporting process that's mainly for large organizations. Or you could, if you're reporting as an individual clinician, you could use claims-based reporting through CMS, although that's really fallen out of favor in recent years for a variety of reasons. And then in kind of making this decision, so this can be, depending on how complex your practice is, can be an involved process, but you have to balance certain dimensions of the decision. So, well, are there, pardon me, was there a, okay, I was afraid I lost my audio again. Okay, good. No messages here on the side. Sorry about that. So really looking at these different methods may have different sets of measures that are available. They may have different fees involved if you're working with a third party. The rate at which you can monitor these performance, how frequently you can get that feedback, that can also vary. And also the benchmarks for the measures also vary from one method to another. Okay, so there's a lot of different aspects to this decision that you need to really look at and make a decision that's best suited for your organization. Leslie, anything you wanted to add about quality reporting before we move on here?
Yeah. So, you know, just looking from a global picture, the first thing that organizations really did was invest in their EHR. And then looking beyond that, in order to move from walking to running, a few things is just making sure that you have enough ECQMs to choose from, so that you have enough configured in your EHR that you can submit on and monitor. And then even further, just ensuring that you have the workflows in place and that you have those resources and the investments made in gathering data for those CQMs. So in the past, you may have submitted, as Tom mentioned, via claims, web interface, registry, but really your better investments on the ECQM side, because it can really be foundational, not only for MIPS, but for other value-based care programs as well. That being said, obviously there may be certain scenarios that would require you to submit via registry or another method, but we would really look at those CQMs to be foundational and really help you jump from walking to running.
Great. And the other aspect of running is also going beyond just those promoting interoperability based measures. Is to really look at improving performance across a broader array of those interoperability measures to further increase your performance score. And this will be important as we start later on. We look at how 2019 is shaping up in the proposed rule, where this PI category will be a greater focus. So, to add to our previous example of walking, so these additional things that you would be doing for quality and promoting interoperability, what might that look like? So within quality, one might decide to choose the EHR or ECQM reporting method or collection type. And these are some actual representative sample numbers that are very realistic in terms of, you can see here a lot of primary care measures, quite typical for this particular reporting method. And each measure earns a achievement score out of 10 points based on how you rate relative to a national benchmark. And then in addition, you can also earn bonus points. So for example, the fact that this reporting method using EHR is considered to be electronic end-to-end reporting means that you then get a bonus point for every single one of these measures. Okay? Now within the promoting interoperability category, you can report on a broader array of measures. You could also look at the measures that were also part of the base score and really look at improving the performance along those lines for patient access as well as health information exchange. And similar to the quality side of the equation, you earn a certain number of points out of a maximum for each one of these based on how you're doing relative to a measurement scale. You can also earn bonus points as well. In this case, for reporting or for engaging, at least engaging an additional public health reporting registry. And there's additional bonus points you could also earn as well. But for this example, let's run with these numbers and see what does it look like on the other end. So for quality, with those measures and performance rates and bonus points, they earn a 47.5 out of 50. Okay, so if you kind of go back and you compare here, there's various different paths to get there, depending on how these numbers turn out, but kind of gives you a little bit of a sense for the relationship between performance rate here and the number of points you're getting out of 50 here. So the promoting interoperability category is that with those additional measures and that higher level performance, in this example is essentially earning 111 points, okay, and it's capped at 100. So that's really 100%. That gives you the full PI score here of 25. And then the other components are the same as previously. So this would all add up to a estimated minimum score of 92.5. You're well above 70, and you really are in a very good position going forward. Okay, so we'll kind of pause here and just talk at a high level with some examples about ways to just maximize your measured performance, particularly for folks in the running mode. And first is that there's great opportunity to align your MIPS effort with your broader goals around value-based care. So for example, when selecting measures for MIPS, using as a key factor, what are those measures that can also align with where your organization already places great emphasis on. So for example, it could be initiatives around hypertension, for example, that might influence how you select these measures. Making MIPS more meaningful for your clinicians. So certainly there's the financial and the reputational piece of the program, But when you're talking about individual measure performance and accountability for that, a lot of great benefit to really connecting the dots for clinicians in terms of how specific measures can really lead to better patient care. Providing them that feedback through mechanisms like scorecard, for example, that's relevant, that's timely, that they can easily understand where they are, and also where they stand relative to their peers. And then finally, there's things that you can do to optimize your reporting and decisions you make around that. So we've talked before about a couple times about how you can decide to report as a group of clinicians in one block or report clinicians individually. And the types of scores you can earn and the financial impacts can actually vary between those two different cases. So there's opportunity there to kind of look at how those two different scenarios stack up against each other to maximize what your outcome is through strictly reporting decisions. One technique that can be useful is if you have if your organization is such that you have a big spread between the clinicians that are doing very well individually on MIPS and those that are more lagging. One strategy you can look at is to actually report both as a group, and that would, if you report as a group, that will allow the low performance to inherit the performance of the entire group, which is likely to be much higher score than they would individually be able to get. But we can also report the high performers individually as well, and let them benefit from a higher score than the group would get. And CMS for each individual clinician will take the higher of the two scores. Okay, and so there's a number of techniques like that that you can look at to kind of optimize the decisions around reporting. And Leslie, anything you'd like to add here?
Yeah, to your first point in talking about the broader value-based care goals for the organization, we have some existing customers in California where there are some statewide programs that these organizations participate in, and they're able to monitor the same CQMs for that program as well as for MIPS. So just again reiterating that that foundational MIPS baseline really translates to other value-based care programs.
All right, so just for sake of time, I won't spend a ton of time on this slide, but just to give you a little inkling of some of the more advanced concepts and aspects of MIPS. So there's this concept that we call measure leverage. And what it is that if you look at these green bars as, let's say, existing performance on a set of MIPS measures, and if you ask the question, if you were to improve performance on one of these measures, let's say the hemoglobin A1C measure by a certain performance rate difference, that will give rise to some increase in the MIPS score. Let's say it's 3 points in this example. But if you look at a different measure, and let's say you're able to take this influenza measure and increase it by a much higher rate of performance change, that amount of change may actually result in a smaller increase in your MIPS score than the change to the first measure. And that's because of the way in which these measures are benchmarked, how the benchmarks are created for these measures, and how they stack up against each other. This measure, for example, here could be a topped-out measure, meaning that the rest of the country is generally doing very well in the measure, so it's hard to get more points out of it. So just something to think about in terms of if you really want to squeeze that extra amount of level of performance out of what you're doing within MIPS, these are some of the things that you can think about and consider in how you focus your efforts and how you pick measures. Okay, so let's take a higher level view of from a runner's perspective of how you can look at MIPS as really a broader change enabler. What we've seen is that often with the introduction of MIPS, or when MIPS changes, and organizations really trying to take their performance up to the next level, or at least maintain their score to be a high score, that effort alone can bring a lot of attention to some concepts around value-based care that are fairly universal. So refocusing on quality, awareness of cost, for example, has come into play within MIPS this year, is really making providers more aware of how they stand with respect to certain cost dimensions, and also exposing the organization to the fact that there is this downside risk aspect of MIPS that will become a greater and greater risk as the performance threshold continues to increase throughout the next couple of years, where you really need to put effort into making sure you're well above that threshold. And it's proposed to, for example, threshold is proposed to double to 30 points next year from this year being 15 points. So bring that attention. Achieving some high scores early on can really create a lot of momentum for change, just to keep that score high, which can also drag along other efforts towards general quality improvement. We've also found that because of where MIPS is going and how it's expanding, that it's a great opportunity for the organization to kind of build some muscle memory around some of the processes and some of the disciplines around for value-based care generally. And as Leslie mentioned before, there's great alignment between MIPS measures and those of other programs. One example of that is on the Medicare Advantage side. So HEDIS measures for physicians, about half of those measures have a MIPS quality measure equivalent. And so that's a great way to kind of explain and the broader potential benefits of doing well within that category.
Yeah, Tom, just to add on to that a little bit, we say, you can use MIPS as spring training for your other programs. So once you've locked down, you've identified your workflows, and you've got your processes in place to really meet those measures, it makes it so much easier to translate those to any of those other Medicare Advantage or any other programs that you're involved with. Absolutely.
Okay. So we're going to come down the home stretch here. Let's talk about what the here and now this quarter. What are some key activities or decisions that you can look at to optimize this year? So one of the key decisions is for many of you that did participate in MIPS last year, one decision is, hey, is there anything I really need to do differently than what I did last year in order to be where I want this year, where I want to be for this year? And there are some things that you can look at. So one item which has come up more frequently is around eligibility. So this year, one of the big changes in the eligibility criteria is change in the low volume threshold, that $90,000 minimum Medicare Part B annual payment allowed charges amount to be eligible for the program. And so if you reported as individual clinicians last year, you may find that this year as an individual clinician, you're excluded from the program because you don't have enough Medicare Part B. Now, if you think you can be well into incentive territory this year, then you're actually going to leave money on the table by not being included in the program. So one way to get around that for this year is to consider is if you are in a practice that maybe is 5 to 10 providers, for example, you might very well find that if you decide to now switch to group reporting, instead of reporting clinicians individually, but really switch over to group reporting, then what happens is that your eligibility is then evaluated as an entire group, where very likely your Medicare Part B charges will now be high enough to then qualify for the program. And then you can now capture those incentive dollars that you would otherwise be missing out on. Okay, so that's something to look at. Look at that participation lookup tool for your eligibility and see if this situation may apply to you. Another thing to look at is just potentially looking at reporting more quality and promoting interoperability measures. The fact that the cost category now is weighted this year versus not being weighted last year, that can actually pull down scores. And so being able to compensate for that reduction with some higher scores on quality and PI may be helpful. Another thing to look at is that about 60% of the measured benchmarks for quality have actually increased in difficulty since last year. And so if you now look at the new benchmarks for this year, you can access that from the QPP portal, that may impact what kind of effort you want to put into having some level of momentum towards improvement, at least probably more moving into next year. But more immediately looking at potentially mixing up the quality measures that you actually decide to report on. That can have an impact on that decision. And then finally, for the PI, promoting interoperability category, if you really had a hard time with this category last year as a small practice, now for this year, there's actually opportunity to apply for a hardship exemption. But it's under pretty severe circumstances, but you can take a look at that in which CMS would grant that to you if you qualify. Okay, so let's now just talk about what will be coming soon, which is submission season in Q1 of next year to submit your data for this year. So first of all is that we're already into the last 90-day window. So for a couple of the categories that we talked about for MIPS, there's a minimum 90-day period. That's already started for this year for these two categories. And so if there's the need to improve performance on the PI category, for example, really have strong focus on that right now. For the quality category, given the range of choices that you have in terms of collection type and measures, and also potentially involving third parties in helping you report this, great opportunity right now to try to get ahead of some of those variables, make some early decisions, and really be able to be ready when the submission season actually opens up in January. Make sure that you have access to the QPP portal for a submission, that you get your credentials early and you get the right permissions granted. That's something that's very wise to take care of before the portal gets too busy during submission season. And then also take a look at your eligibility list from the QPP portal to see whether there are any surprises, such as what Leslie had mentioned before, in terms of clinicians that may be practicing in multiple or under multiple TINs, things like that, things that may be items that you want to ask CMS about, really match your understanding. Okay.
Tom, a couple other things.
Yeah, go ahead.
In thinking through submission, so another item is audit documentation. So specifically on the improvement activities category, as you're looking through the list of activities, it can be tempting to just select activities that you know you're already completing. However, we'd really recommend that you select activities that you're already doing, but that you also have documentation to support. So just a reminder, MIPS is an auditable program still, and you may need to show evidence if you are audited that you are completing those activities. So collecting any audit documentation that you can in advance of submission rather than scrambling as that deadline approaches is always helpful. And then if you are submitting through your EHR, a lot of times the EHRs may have internal deadlines that fall in advance of the CMS deadline. So just be aware of any additional deadlines that may be out there in order to get your data submitted. And then the last thing that I would recommend, as Tom mentioned, is making those decisions in advance. So if you could make the decision on group or individual, which way you want to go within the next couple months before submission, that way you're prepared. You can ensure that you have data for all of the clinicians that you need to submit on, and it's not a rush right as the deadline approaches.
Yeah, and I think that submission is something where there's a lot of moving parts, and it's a great opportunity, I think, at this time of the year to also engage organizations to assist you. So certainly CalHIPSO's got a lot of resource and experience here. What we've seen is that really working with partners, organizations that see a lot of different use cases around submission can be very, very helpful for you to more quickly identify what's going to be your optimal path and what are some potential pitfalls that you can avoid. So please take advantage of that as well, any opportunities like that. Okay, so now let's look ahead to what's around the bend in 2019 for the MIPS program. So back in July, CMS published the proposed rule for next year, and the comment period's already ended, and there were 15,000 comments submitted, not just on QPP, but other aspects here, so that were in that proposed rule. So that will be coming out hopefully not too close to December 31st, but we'll see. But if you look at the proposed rule, the way that it's impacting MIPS, the first question that comes up is, well, to what extent has the program potentially become more difficult? And one way to kind of get a sense for that is to take a look at what has been some historic performance within the MIPS program from a measure perspective, and then take a hypothetical situation in which, if that performance were to be subject to the 2019 proposed rules for MIPS, then what would be the MIPS scores that would result from that? And so we carried out that exercise for a number of organizations that we're familiar with. And what we find is that typically there's about a 12 to 16% drop in your MIPS score from 2017 if you were to apply the 2018 proposed rules to it. And there's kind of a couple drivers behind that, one of which we'll go into a little bit more in depth, which is that the promoting interoperability category is getting substantially harder next year, according to the proposed rule. And then another dimension of another driver behind this average decrease in the score is the fact that the cost category is going to increase in weight. And the cost category is something where it's generally harder to move the needle on. And so it can tend to have a dampening effect on scores. So that's the first thing to look at is sort of at a high level, what could happen to your score going into next year. Now, from a financial perspective, the performance thresholds that are the dividing line between those who are penalized versus those who earn incentives, that's doubling from 15 to 30 points under this proposal. And then the exceptional performance threshold to get into the zone of accelerating incentive at the top end is increasing from 70 to 80 points. And so if you factor in the difficulty of the program increasing and these threshold changes, what CMS is currently projecting for next year is that if one were to score at 100 points, there would be about a 5.7% adjustment. So substantially higher than what it's projected for this year and what it was last year. These numbers are not final yet. We'll see more in the final rule. But I think one thing you can say for sure is that the incentive is going to be materially higher next year than it has been in the past. The penalty will also expand to be 7%. And so the spread between maximum incentive and penalty will continue to grow. The other thing that, in fact, many of our organizations that we work with now are already starting to look at this is that there's proposed to be new clinician types that will be eligible for MIPS next year. Physical therapists, occupational therapists, social workers, and clinical psychologists. And then also there will be the ability for some of those low volume clinicians to actually opt into the program if they meet certain conditions. So that will have the effect of expanding the number of clinicians that can participate in the program. Okay, so one of the headline proposals for next year is how the promoting interoperability category will radically change if the proposal goes through. And this is really all driven by CMS's laser focus on really trying to make interoperability more pervasive in terms of patient access to information and the data liquidity between organizations. And so the first thing is that next year it's proposed that technology, certified technology has to be at the 2015 version. The 90-day reporting period would still hold, so you'd have more time to try to find that best period. But the scoring will be completely revamped, is that there would no longer be a separate base and performance score. Instead, just straight scoring of these measures on a basically on a continuous scoring scale. So what that means is that in order to that there will be a more limited number of paths to get to 100 points full score on this category because of really narrowing down the number of measures, but also changing the way in which it's scored. A number of these measures are more difficult. So for example, these health information exchange measures, under the way that promoting operability is today, there are many paths to get to a full score on this category without doing well on information exchange measures. But under the new scoring, really, there's a very narrow path to get there, and you really have to do quite well on the information exchange measures in order to really meet really be able to get the maximum. Okay. Leslie, was there anything you wanted to add before I move on around PI?
I think you hit the nail on the head. Really, just 2019 is going to be more difficult. It's more based on performance, even if you're submitting at that group level. And although you may have had full category scores on PI in the past, that's not necessarily the case for next year. So just be prepared for what's coming in 2019.
All right, well said. Okay, so last slide, we might be able to take a couple questions here. So one prediction, maybe it's bold, maybe it's not, is that many walkers today will become runners for next year, given where the program's headed and the momentum that's being built up. So with that, Chloe, I'd like to hand it back to you. If there's any questions that have come through.
Yeah, we have a couple questions, and it looks like we have about 5 minutes left. So the first question is, would you check, so this is referring to CMS's participation lookup tool, and the question is, would you check a FNP and a PA's MPI here also? So family nurse practitioner and a physician's assistant.
Yeah, Leslie, do you want to take a shot at that first?
Yeah, so you can check those there as well. I would recommend reviewing the eligibility for all of the included provider types, and then also for the provider types that are going to be included for 2019 as well.
Great. Okay, so our second question is, it says, I am just starting in a primary care this month, and I had been doing hospital work for the past 2 years. Do I need to do anything this year?
Yeah, so I think the first step is certainly looking at the eligibility tool to see, really immediately if you're excluded from the program or not. And I think the second thing is, given your primary care activities right now and kind of the environment in which you're working in, is to first, find out if your organization has some existing efforts around MIPS. I don't know if it's a solo practitioner or not, but to really ask about that proactively in terms of what are, for example, what was the MIPS reporting path for last year? What did that look like? What do I need to do as an individual clinician in order to be part of that, or to make sure that I'm on board with that? And then I think the third thing is, in terms of what you can do now at this point of the year, is to get clarity on, how will the reporting be done, going into 2018. Am I going to be part of a group reporting? Am I going to have to, or stand alone and be reported individually for the program? I think that can kind of provide some useful context around, what are the levers that you really need to focus on and that you have control over now that we're towards the end of the year, and how much can you benefit from what the rest of the organization is already doing.
Great, thank you. Our next question is, do you have to pick different items from what you picked last year?
I'm assuming you mean on the improvement activities category. No, you do not. You can use the same activities that you submitted in 2017.
Great. I think we have time for maybe one more question. How about if I report through an EHR registry, how do I know for sure that CMS sees my data submission before the filing deadline?
Great question. So if you report through, and we'll assume that EHR registry means really using the registry reporting method, is that when registries report on behalf of an organization or a clinician, they do get a confirmation ID back from CMS. And so that's a very reasonable thing to ask for from your registry provider, is to get that ID number, because it's a good reference point should there ever be problems or you want to dispute your score later on. I mean, it also confirms that they've actually received the submission. If you report, let's say if you report on your own through the QPV portal, let's just add in another example. You will see some indication of a confirmed receipt within the portal. I believe that, Leslie, is that the case? I'm having trouble remembering what the artifact is that you get back from the portal. if you report on your own.
Yep, that's correct. So if you report on your own, or even if you submit through your EHR, you will see the data that's entered when you log into the QPP site, and you can see the estimated score is actually populated in real time. So you would see that submitted data there.
All right, and with that, this is David Ford again, and we are coming up very rapidly to the top of the hour. So I want to thank our colleagues at SA Ignite. Tom and Leslie, thank you for being available today and for being part of this webinar. We had more questions come in through the question box than we had time to answer today. So for folks, if we did not get to your question and you'd like us to follow up, you see that email address right there on the screen, info@calhipso.org. Please feel free to send your questions to us through that email address, and we'll try to follow up as best we can. Also, a recording of today's webinar will be made available on the CalHIPSO website, as well as the CalHIPSO Webinars YouTube channel within the next couple of days. And last but not least, as you see up there on the screen, I do want to make one little plug for CalHIPSO's first conference, which will take place in Sacramento on Monday, May 13th of next year. Hope to see many people there. We're looking forward to a very exciting event. Again, thank you everyone who attended. Thanks Tom and Leslie and the team from SA Ignite for putting this together and for being part of it. And with that, we will wrap up the webinar.
Thank you.
Thank you.